panelists, Dr. Hamad Usmani, Dr. Dipender Kaur, Dr. Subrata Goswami, and Dr. Devender Singh. Dr. Devender was somewhere in the COVID duty, is just returning back, so he'll be joining a little late. Dr. Sakanya Mitra, she is not able to join because of some exchange in services, so she won't be able to join us. So we'll start with this panel discussion. Before that, I'll explain all of you the rules of this panel discussion, online discussion. We have some limitations with the online system, so that we have to keep in mind. And obviously, we cannot do much about that. This will be more of the one-sided. You'll be seeing this panel discussion, but you can put your questions, whatever your comments or questions you have. We will request you to restrict your comments or the questions related to this topic only, because otherwise what will happen that if the chat box is full, then we are not able to segregate the relevant questions. So keep putting your questions over there in the chat box. So in between, me and Dr. Kailash Kothari, our president, is there. So we'll be sorting out those questions and we'll be putting those questions to our moderator and the panelists. During entire panel discussion, we'll be keeping all of you mute. That will be forced mute for everyone. The videos will be forced off for everyone. So that is not for anybody particular people. That is for all the panel, for all the participants who are there in this panel discussion. The video and mic is on only for the moderator, panelist, and me and Dr. Kailash Kothari. So that is a rule of the game. So we'll be sending another one. Okay, one other one good news is that I'm not sure about for this CME, but I have spoken to DMC, Delhi Medical Council, and they agreed to give PME credit hours for the online program also. So that is one good thing has come up. That actually he confirmed me yesterday only. The DMC
Congratulations, congratulations, sir.
So he just confirmed me yesterday. So and yesterday, Saturday, and then Sunday. So and they are very busy in the COVID duties and everything. So, but I'll try to get all the CMA hours for our previous one also. But definitely from the next onwards, whatever we are going to conduct, we'll have the CMA credit hours for those. One more thing is at the end of this or in between, we'll be sharing some links to you for the survey. Now, this is very important for us because whatever ISSP is doing, these are not for the personal use. These survey are not for personal use. These are for the society. These data is required. This feedback is required from the members. It is very important for us, all of us, to reply to those surveys, to fill those surveys, to participate on those surveys. So far, let me tell you, our experience has been very bad. Out of 3,000 members, we are getting reply not even 100. So that is not good for the society because we want these surveys, we want these data for the publications. Okay, so at least I think 25% of the response is required to publish anything, and we are not getting even 5%. So which is why we are not able to even publish anything. So I request all of you, we'll be sending some surveys to you. Please fill those surveys. Please reply to those surveys. That will not take more than 2 minutes, not even 2 minutes. It will not take more than that. It's very simple. You just have to go yes, no, and then you have to submit. That's it. Okay. So with that, I'll request our president, Dr. Kailash Kothari, to please say a few words for his opening remarks.
Thank you, Pankaj, and welcome everyone here. And on this Sunday morning, we are again ready with one of the very burning topic in pain management, that is neuropathic pain, and some wonderful work has been done by our panelist, Dr. Saxena and his team. And Dr. Hamad Usmani has already published these guidelines on Indian Journal of Pain, and we need to understand what are these guidelines are and what are the challenges we are facing in neuropathic pain. And I think that will be one of the very good session. I invite all the panelists to start the session. And before that, again, I am also requesting everyone to take part in the survey because this is very important. And please do it immediately as soon as we finish this panel discussion, so that we get all the data immediately. So that if you go home after the survey, you should not forget it. So one is that, and second, we have a we have all India pain physicians video, which is compiled by Dr. Hitesh Patel. We are going to release it immediately after the panel. So be there till the end of the session so that you can have a very good experience of watching all the pain physician dancing in lockdown. So you can start now, Pankaj. Yeah.
So I'll hand over to Dr. Professor Saxena for this wonderful panel discussions which is going to conduct. So over to you, sir. Sir, you are not audible. Can you just increase your volume?
Unmute your mic, sir. Unmute your mic.
So you unmute.
Yeah, am I audible now?
Yes, yes, yes.
Okay.
No, you are.
Very good morning, and at the very outset, I wish to express my deep gratitude to Dr. Pankaj Surange, Dr. Kailash Kothari, and of course the entire organizing team. You know, they have really taken pains in these hard times of COVID, but I'm sure we all are going to win the battle. And you can understand my hospital also, in addition to many other hospitals and all across the nation, are going to have the, you know, the sprinkling of the rose petals by the Air Force, Indian Air Force, and all those. Thanks very much indeed. When we start with the topic, and this is where, you know, millions and millions of people afflicted with neuropathic pain, chronic neuropathic pain, all across the globe, all those 6-7 continents are actually afflicted. And this is where you find that, yes, this particular condition remains underdiagnosed, undertreated, and is associated with all those usual physical, psychological, and economic consequences, compromising with the quality of life. And obviously, it's a great burden on the community, great burden on even on developing nations like India. You can imagine when you count the numbers of chronic neuropathic pain patients in millions together. So the whole burden is colossal, in fact. And that is where you find that you have the experts. And I can tell you that this particular guidelines, when we were actually asked to bring it out, we held a discussion. So the contribution is very much from all the contributors. You find this particular 2018 December Indian Journal of Pain publication. So all of them are responsible and they all have worked very hard. But yes, there are always certain deficiencies, and which we will talk about. But so this is where you find that chronic neuropathic pain. If I can share a few of my slides over here, I'll be just doing that. And this is where you will see that, well, is the screen, am I sharing this? The slide is visible, am I right?
So you just need to click on the slide. We can see your desktop.
Okay, on the slide, all right, okay.
So on the presentation, yes, sir.
Okay, just a second, please.
Perfect, sir.
All right, okay. Thank you. So this is where, you know, it's something like we have been doing triaging, you know, in the, what should I say, in the COVID patients for mild, moderate, and severe. Same way you have for the diagnosis of neuropathic pain, you have a possible, you have a probable, and you have a definite diagnosis of neuropathic pain. If I say criteria number one, that pain that is a distinct neuroanatomically plausible distribution is very important. Then there is history which is suggestive of a lesion or disease affecting the somatosensory system. The third criteria is that there should be a possible demonstration of the distinct neuroanatomically plausible distribution on the patient. And the last but not the least is actually the demonstration by at least one test for the underlying lesion or disease. So if I say that criteria number 1 and 2 is for the possible neuropathic pain, probable is when you have easily demonstrated the distinct neuroanatomical plausible distribution on the patient, right? And of course, this definite one is where you have been able to demonstrate at least by one single test the underlying lesion or the disease. And by that here, you mean you may have diabetic peripheral neuropathy, you may have, you know, post-herpetic neuralgia. So accordingly, you can do at least one test. Right. So this is where you find the definition is very much, everyone is aware of that. There's a pain arising as a direct consequence of a lesion or disease, which is actually affecting the somatosensory system. And I need not bore you with all the underlying causes. All of you are very much familiar with the various multiple causes of neuropathic pain, the central one, the peripheral one, and of course the mixed type. And you know, this is where you find the only thing which you will not find over here is cancer. And that, you know, cancer induced neuropathic pain, like you can have chemotherapy induced neuropathic pain. This is where you find that a lot of references are there. These references right now in front of you, they, you know, the topmost one you find started in 2008 by the Indian study group, and then you find many others. There are a few done by general physicians also. That's why you're finding Datta and other names which are there, and Narayan and all that, because they are mainly related to the diabetic experts. And then these two, I'm sure they are the authorities. So on neuropathic pain in Indian cancer scenario by Dr. P.N. Jain and Dr. Sushma Bhattacharya. This is just for the sake of bringing out that yes, this is the contribution that we had utilized during the framing and the writing of the Indian pain guidelines, right? So with this, we move on to there are so many of them: European one, Canadian one, and then the Australian one, American one, and then the most famous, because ISSP being the Indian chapter of IASP, so we are actually sticking on to NUPSIS guidelines as a benchmark. And this is where, because otherwise it's not possible to cover up everything over here. This is where now I will move on to our first panelist, Dr. Dipender. Dr. Dipender, I would be requesting you to actually, how exactly do you want to enlighten the audience with the famous NUPSIS guidelines for diagnosis of neuropathic pain? That means we are starting with the assessment part first. Dr. Dipender, please.
Okay.
Yeah, over to Dr. Dipender, please. Yeah.
So
Yeah,
Wonderful.
I'm not able to go further. I'm not able to go for next slide. Just a minute, sir.
okay.
No problem.
Yes.
Right.
Thank you, sir. Good morning, everybody, and my special thanks to the Dr. Pankaj sir, Dr. Ashok Saxena sir, and Kailash Kothari sir for inviting me for this webinar. I think I'm audible, sir.
Yeah.
Yes, you are.
Audible. Yeah.
Hi.
So as it has been explained by Ashok Saxena sir about the neuropathic pain, and we all agree with the fact that the severity of this pain is the reason that it is having so much impact on the life of patients. And we all agree with the fact that in all the guidelines, whether it is European guidelines or we are following the neuropathic pain special interest group guidelines, they all are agree with the definition of neuropathic pain, that is any pain which is caused by lesion or disease of somatosensory nervous system. Here I'm highlighting only the key points when we are going for a patient who is having neuropathic pain. We see that patient is having a sensory deficit in the painful area. Some patient may have allodynia or hyperalgesia in the painful area. Patient may have the temporal and the spatial component of the pain, like they may feel after sensation or poor localization. Sometimes with repeated stimuli, you will see the patient will have gradual pain in intensity. And two paradoxical clinical feature we see in the neuropathic pain, that is the loss of sensation and increased sensation. So this two paradoxical features which we see in these kind of the patient, it clearly demonstrates that pathophysiology is really very complex. So we have the differentiation as well as the neuronal hyperexcitability when we talk about the neuropathic pain. So right now we are discussing about the assessment part. So as a pain physician or as a clinical researcher, when we want to assess the patient of neuropathic pain, we really want to categorize them into two subgroups. Number one, we have to assess the pain intensity, quality, and possibly their treatment induced changes, right? And second thing, here comes the part where is how we can diagnose the neuropathic pain. So in 2016, the revised grading system has been upgraded, in which we are using the grading system just to certain that our level of diagnosis. As sir has already told about the grading system, so this flow chart is really very helpful in clinical practice when we really want to see our patient of neuropathic pain, and when we see that this question, the pain which is in the question is really neuropathic or not. So this is an approach in which we are going stepwise, right from the history to clinical examination to the confirmatory test. But at every level, we are trying to meeting certain criteria so that we can go to the next step. So the beauty of this flow chart is that we can have certain criteria, so we can certain the diagnosis, whether it is a possible pain or it is a probable or it is a definite neuropathic pain. So step one, in the step one we have seen it is the history as well as the pain distribution pattern in the neuroanatomically plausible distributions. So like in any patient, first of all, most important thing, we have to believe the patient. In the neuropathic pain patient, they will describe their pain in number of terms like lancinating pain, burning pain, or it is a shooting electric pain, or it is a stabbing pain. So we let them listen the patient. We have to see the patient, its pain complaint as well as the abnormal sensation which patient is having, right? So whatever pain patient is describing, ultimately we are measuring the intensity of the pain, and to measure the intensity of the pain, our guidance recommend that use of numeric rating scale and the verbal rating scale, because the visual analog scale is little difficult in the elderly population. And if we really want to see what is the treatment response when we start the treatment, we can use the neuropathic pain symptom and neuropathic pain symptom inventory guidelines to assess our response to the treatment. So here we are looking for the history part of the patient. And then comes the certain screening tools. These certain screening tools like the lead assessment of neuropathic symptoms and signs and self-reported symptom, and certain tools like the neuropathic pain questionnaire and neuropathic pain in 4 questions by French Society, Pain Detect, and the ID Pain 18 questionnaires. So all these screening tools, they have two types of the categories. First, in which there is involvement of physician. So like in the lead assessment and self-reported lead assessment, there is involvement of the physician, and in DN4 also, because we are demonstrating certain signs and symptoms for the to categorize the patient that it is having neuropathic pain. But few questionnaire like the NPQ, Pain Detect, and ID Pain 18, these are the self-reported by the patient only. So we can use these tools in the two categories cases. Like if the primary pain physician is not very expert in neuropathic pain assessment, they can use the self-reported questionnaire. But like pain physicians, we can use the LANS and self-reported as well as the DN4. So patients of the neuropathic pain, they normally describe their pain. Either they are having spontaneous pain or stimulus evoked pain. So in the spontaneous pain, patient may have intermittent or paroxysmal attacks of the pain. And among the stimulus evoked pain, we categorize them two categories. First is the positive sign and second is the negative sign. Among the positive signs, we have allodynia, hyperalgesia, hyperpathia, and hyperesthesia. We are all familiar with these terms, I hope. And the negative signs are hypoesthesia and hypoalgesia. Important thing is that the patient with pain also complained of certain abnormal sensations like dysesthesia and paresthesia. So dysesthesia is abnormal sensation which is really unpleasant for the patient, like pins and needles. But paresthesia is the sensation which need not to be unpleasant, like tingling sensation. All these sensations, they help us to make the diagnosis possible in case of neuropathic pain. So now comes the step two. Step two is our clinical examination. So clinical examination has been given a priority in our new PSIG guidelines. We have to see that the clinical examination, why we are doing clinical examination? We are doing clinical examination just to support or refute an hypothesis which we have derived from history. Suppose the patient is giving the history of some herpes zoster infection and now patient is suffering from pain. So to confirm this hypothesis, we have to do certain clinical examination, mostly sensory examination we are doing for somatosensory nervous system involvement. And similarly, the patient is having an injury, history of injury to the nerve plexus. And when we see the sensory involvement by clinical examination. So we really want to refuse or support an hypothesis which we have derived from the from our history part. Among the clinical examination, we have certain negative sensory signs and positive sensory signs. Among these signs, it is very important in the guidance written that negative sensory sign along with the distribution of the suspected lesion territory is highly pathognomic of neuropathic pain. In day-to-day practice, we are doing certain bedside sensory examination and they really help us to make the diagnosis it is a probable neuropathic pain. So positive sensory sign, they have been given less weightage for the pathognomics of neuropathic pain. The reason is that the positive sensory signs, they can be seen in the patient who are suffering from nociceptive pain. It can be seen in the patient who have anxiety disorders or they have the generalized pain or fibromyalgia like conditions. So they are not very much pathognomonic. Of course, the negative signs are more pathognomonic. But if we really want to go for detailed examination of sensory system, we may need to add quantitative sensory testing in the clinics. So these are the certain sensory tests which we are doing in our patients of neuropathic pain for the perception of touch, vibration, pinprick, by the sharp pain, cold and warm sensations, because all somatosensory nervous system is actually about the sensory perception of our body parts, whether it is a skin, muscles or viscera, right? So we are basically concentrating when we are talking about the somatosensory system, we are talking about sensory part. Of course, the autonomic and the motor involvement can be seen, but not necessarily in all patients. So now coming to the step 3. So step 3 is confirmation by diagnostic test. Of course, we do not have any gold standard diagnostic test for the diagnosis or assessment of neuropathic pain, but still our guidelines, they recommend, they focus on certain reflexes, evoked potentials, microneurography, functional brain imaging, and skin biopsy, right? So first of all, we all are, one more interesting thing which I came across during this discussion, that we are thinking about it is only the A delta fibers and the C fibers which are carrying the pain sensation. But certain studies, research studies, they have shown that there is involvement of the A beta fiber also in the case of pain pathways. And this is the reason the A beta fiber mediated trigeminal reflex is considered useful when we really want to differentiate the patients of symptomatic or idiopathic trigeminal neuralgia, because this reflex is absent in the patient of neuropathy because of the trigeminal neuralgia. And these guidelines also suggest about the evoked potentials. So whenever we are doing the evoked potentials, our idea is that we are giving the electrical stimulus to the brain through the sensory system, right? So normally this reflex is mediated by the A beta fiber, because A beta fibers, they have low threshold for electrical stimulus. So whenever we are trying to assess the somatosensory evoked potentials, we are actually stimulating the A beta fibers, and we are not able to assess the neuropathic component of pathway. So to assess that, now recently they have written about the laser evoked potential, and especially the late laser evoked potential, because in the laser evoked potentials, by using the radiant heat or laser, we are stimulating the nociceptive pathway. So it is very much diagnostic for the small fiber neuropathy, but it is limited because of very limited center. They have this facility. It is going cost effective is the issue. Microneurography and the functional MRI, they are as such not recommended in the routine clinical practice, but they are coming in the bigger way because they have the converging evidence that patients with a neuropathic pain, they have the decreased activity in the contralateral thalamus when we see in the functional MRI. And this is really can be helpful in the future when we want to titrate our response to the treatment. So minimally invasive technique of skin punch biopsy, it is recommended for small fiber neuropathy, because nerve biopsy as such, if you want to go for the nerve biopsy in the small fiber neuropathy, it is not very much diagnostic early stages. But this technique is very easy to use. The skin punch biopsy is very easy. Under local anesthesia, you can have the skin punch biopsy. And if you see the decrease in the content of intraepidermal nerve fiber density, it is very much diagnostic in case of small fiber neuropathy. So I will rest my presentation on the assessment of neuropathic here only, and I will hand over this baton to the next speaker. Thank you so much.
Right, thank you. Thank you, Dr. Dipender. Thank you so much. Now, the next one we move on. Can you, okay, I'll have to move back again to my screen again here. And that's, yeah, all right. So we share the screen and we go back to this one. That's right. And this is where we move on now to the next one. It is, okay,
Okay, Dr. Saxena.
Yeah,
We have
please.
few comments and few questions
Oh,
also.
please,
So,
Dr. Kailash, please. Dr. Kailash,
there's
please.
one
Yeah.
question which has come from Dr. Uma Shankar.
Right.
What is the exact mechanism of chronic neuropathic pain-induced anxiety? Which they want to talk about psychological.
Right.
You want to cover now or later?
We can cover right now also, later also, as you permit. Is it
No,
possible?
No, sir. You decide. Yeah.
Is it possible that we cover up and we do it in the end? I'll definitely remember it. Is it okay?
Yeah.
Right.
And the second comment is Dr. Rekha Alim Chandani is just sharing her this thing that she uses thermoprobe to help in comparing thermal changes in affected part and help in diagnosis of neuropathic pain.
Right.
And another thing is Dr. Ahmad, he is asking about role of ultrasound in diagnosis of neuropathic pain. Assessment.
Okay.
Is there any role?
Can we keep it for the end?
Okay,
because,
fine.
Yeah, that we can
go
on
ahead. Just keep it this in mind.
Right.
So
okay.
You don't miss the questions because there will be many coming over time.
Yeah, that's right. Thank you.
Yeah.
Thank you. So I have to move on further, but it is not moving. Uh,
So on the left side, sir, left lower corner, left lower corner.
no, the screen
Yes.
is there, but the slide is not moving. Anyway,
So,
No, sir, you have to click on the next, the down there's an arrow on the left side,
on the
on the
left
left
corner.
okay,
corner.
okay, over
Yeah.
there. Okay.
Yeah.
Right, right. That's right. She has covered up all that. And this is just simply to cover up of whatever Dr. Dipender has talked about. I think there's one slide which sums up everything, you know, including the mechanical aerodynia and the thermal hyperalgesia, which you can have, and the sensory deficit. And this very interesting one, which she talked about, I think all of us know it very well, that if you compare two typical modules of neuropathic pain, like if I say diabetic peripheral neuropathy, where there you'll find that it is almost in 64% of patients they have seen sensory loss. In about 20% of patients they have seen mechanical hyperalgesia, and about 14-15% they have seen, you know, the thermal hyperalgesia. Now this is in sharp contrast to post-herpetic neuralgia. When you actually see in post-herpetic neuralgia, you find that the mechanical hyperalgesia component is almost 45%. The thermal hyperalgesia component is 35%, the next one, whereas the sensory loss in post-herpetic neuralgia comes to around 20%. You know, it's a big series of more than 1,100 patients where the authors have actually contributed a lot in that particular direction. And in fact, the one which she was talking about, the skin biopsies, yes, they're more of a research work. They have seen, but you know, many of our patients, when they present with burning pain in the extremity, especially in the lower and the distal part of the extremity where diabetes is not there, you know, many times we forget that, yes, it may be a case of small fiber neuropathy. And using that particular thing, they have seen that it is something like the quantification when you want to do for the intraepidermal nerve fibers, you find that it is highly disturbed in patients of small fiber neuropathy. So that's one of the examples that I thought I must talk about it. Right. Now, this particular one, I'm sure we want to move on more towards the guideline. That's why I'm trying to skip out all these things. But just remember that all the fibers which she has talked about, and she's already covered up all that. We have covered up the role of microneurography, but microneurography has a very special role, especially because they have seen that diabetic peripheral neuropathy, which is so common in India, and of course in all diabetic patients all over the globe, they have seen an, you know, an abnormal pattern of firing which has been seen using microneurography, where you take the electrode right onto the nerve fascicle and you find that abnormal firing happening over there. Right, so the primary sensitization and the secondary and the central sensitization is something which I want to skip, because otherwise, yes, in very brief I can talk about it, that when you see in the presence of inflammation, you find the primary sensitization is happening. There are nociceptors, and nociceptors, you know, in the presence of inflammation, their pain threshold gets lowered, and when their pain threshold gets lowered, naturally they become extremely sensitive, and there is an augmentation and increase in the magnitude of the response to noxious stimuli. And at the same time, there is an activation of all those, which you call as the silent or the sleeping nociceptors in the periphery. They get activated. So again, there is an augmentation. And these same afferent pain signals, when they are traveling onto the dorsal horn, and you find that when they are traveling, there is an activation of the low threshold mechanoreceptors, which are located in the dorsal horn. So that results in a phenomena that means amplification and central sensitization, where you find that even a sensation like touch is able to acquire the ability to produce pain. By that, you know, allodynia and hyperalgesia happening over there. And then there are a number of neurochemical drivers. What you're seeing here, the neurochemical or the neurotransmitters which are there, which actually they are involved in the modulation of pain perception, and you find they are resulting in the complex interplay of events which are actually which actually underlie the pathology of that particular condition. So I'm just skipping these slides. They sum up everything which I've talked about. All right, and the whole this gamut of neurochemical or the neurotransmitter drivers which are there, which actually result in complex interplay of the events. Right. So this is where you find that now the kind of stimulus, you see what is normal pain response and what you see in neuropathic pain, where it is the whole graph is actually shifted onto the left. So this is where now we are moving on to these guidelines, and in these guidelines we have the first panelist, the second one, of course, in the order is Dr. Hamad. My question to Dr. Hamad, that is it true that various meta-analysis and systematic reviews of neuropathic pain and specific neuropathic pain condition indicate that only a minority of patients with neuropathic pain have an adequate response to drug therapy? Dr. Hamad, please.
Morning, everyone. Good morning, sir.
Thank you.
I think, sir, that's a very relevant issue, and that's a very important, debatable issue nowadays. That only a minority of patients with neuropathic pain have an adequate response to drug therapy, and we'll come into discussion of these points when we'll further elaborate on the discussion. But yes, that's true. That only a minority of patients and they showed an adequate response to drug therapy, and that's why we'll not able. We have a lot of negative trials on even on the commonly used drugs, which have a very good level of evidence. But still, we have a good number. We have a large number of trials which are negative, in spite of the high level of evidence with these drugs. So that's very true, and we'll substantiate these things in our coming discussions in the coming slides.
Right. So is it true that many negative trials, they fail to identify the responder population? And can you justify this statement? You know, the negative trials failing to identify.
Yes, yeah. So for that, I just want to bring my slides back into, if you allow me, then
Yeah,
I just,
please do that. Yeah,
so,
please.
so I just want to bring here an important discussion, very important discussion that, uh, in a part, we have different etiologies for neuropathic pain. But once we study a particular etiology of pain, we'll find there are different sensory profiles that are there in one particular etiology of pain. And I just want to depict here through a bar diagram, which is a very important diagram here. And here you can see that uh, patients with different etiologies have different sensory phenotypes. And this is one of the study which was conducted recently by Rolf Baron, who's a big neurologist and neuroscientist. And he studied different etiologies. He divided different etiologies into three different sensory phenotypes.
Can you project your slides, please? Yeah.
Right. Sir, I'm projecting it. Is it coming?
It is not coming.
It's not coming. I'm already projecting it. I am not share screen. Okay. Let me. Okay. Is it coming now, sir?
Yeah, it is there. It is there. Thank you.
So this is a very important bar diagram regarding which I am discussing here. That this is a study conducted by Rolf Baron in 2018 and it was published in Pain Journal. And he found that there are different etiologies for neuropathic pain. But if you see different sensory phenotypes in these different etiological conditions of pain, he has characterized all these sensory phenotypes to three main sensory types. And the blue one is the sensory phenotypes, which is there with sensory loss. They are predominant sensory loss. The red one is basically the thermal hyperalgesia. And the yellow one, which is we commonly see in our practice and we manage it here, is the mechanical hyperalgesia as a result of central sensitization. And he found that all these three sensory profiles, they exist across all the different etiologies. Although it is true that there's some sensory profile, they are characteristic of certain etiological conditions. Like if I see the blue one, which with predominant sensory loss, then they found that it is commonly seen in patients with polyneuropathy, like diabetic neuropathy and lumbosacral radiculopathy. Why the red one is more common in patients with peripheral nerve injuries. The red one is, it's like peripheral sensitization because of the irritable nociceptors. And the third one, yellow one, which we called it the central sensitization as a result of mechanical hyperalgesia, hyperesthesia that we usually see in our neuropathic pain clinics. Then here, this is the one which is usually seen typically in patients of post-herpetic neuralgias. So you can see it here that across the different etiologies, you will find all three sensory phenotypes are there, although they are characteristic of certain conditions, but they can exist with each other. All these sensory phenotypes could exist in one particular etiological conditions. And because of the heterogeneity of these sensory phenotypes, we do not, the drug trials, we do not have an adequate response to drugs. So the future strategy, which is being planned for neuropathic pain management in 2017, 18, 19, and recently also, is to manage the cases on the basis of these sensory phenotypes. So this is what we are going to see in future, the management of neuropathic pain across different etiologies based on these sensory phenotypes. So so this is the basic reason. So you have asked me why there's a lot of negative trials or why there's not an adequate response to drugs. It's because of the heterogeneity, distinct pathophysiological mechanisms which which underplay in different types of sensory phenotypes. And because of these different distinct pathophysiological mechanisms, we have a differential response to treatment. That in a one particular condition, you have one drug which is working well, while the other drug which is not so good. But in a similar patient with similar etiology, in a second case of similar etiology, you'll find some other drug is working well. And that's the basic reason for a lot of negative trials with neuropathic drugs in these patients. So in future, we will expect that these sensory phenotyping will help us to lead a more stratified treatment and more personalized pain therapy based on these sensory phenotypes. Now, this is, I just want to share one more last chart here. Is, this is a clinical part here, this is the applied part here, that they found that patients who have more of a mechanical hyperalgesia that we see in patients, typically seen patients of neuropathic pain with central sensitization, the drugs like gabapentinoids and sodium channel blockers, they work well, while patients who have peripheral sensitization, in the form of thermal hyperalgesia and irritable nociceptors, the topical drugs, they act very well. You'll find that the topical analgesics like your Botox, and we'll discuss in detail, and capsaicin, they play an important role. While they are not so, their role is not so important, it's not substantiated in patients with mechanical hyperalgesia and in other group conditions. Patients with sensory loss, which we usually see in patients of diabetic neuropathy and retinopathy, there is a strong depressive component in such patients. So the patients respond best with your antidepressants along with the other drugs like your gabapentinoids, and certain opioids like tramadol have also play an important role in such conditions. So if we can stratify the therapy based on sensory phenotypes, in future, we could have a better response, we could have better results.
Right. Right. Thank you, Dr. Ahmad. The next question to you is that could you please update us on the evidence-based usage recommendations, and could you easily compare it with, the Indian guidelines? And this is in the context of the role of pregabalin and gabapentin in the management of neuropathic pain, please.
Okay, sir. Thank you. So let me come to my next slide. Once we publish our trials, our studies, our guide recommendation 2017, we have studied several guidelines, and this is one of the most important guidelines, the updated neuropathic pain special interest group recommendations. And this is one of the guidelines that we consider while publishing our recommendations for in the management of neuropathic pain in India. And why this is important here, that they have used an important system which is called as grade system. And this is basically, what they did it here, we have the level of evidence, we have the level of recommendations here, but actually they grade the recommendations here. They grade the level of evidence in terms of, like, if a drug has good level of evidence, but has a large measurable side effects also, then they put that drug instead, in spite of good level of evidence, in the low level of recommendation or weak recommendations. But as you can see it here, that if the drug has a very good level of evidence, and on the other hand, and at the same time, the level of side effects, the desirable effects outweigh the side effects, then they put it under strong recommendations. But if the drug level of evidence is low and the side effects is also high, then they counted it as a weak recommendation. So this is an important thing that they follow in their guideline, that it's not the level of evidence, but it's it's a side effects, there are other issues which we also take into account when we publish our guideline 2018. And the important thing that we consider here in our country is the availability of the drug and cost and affordability of the drug, besides the other cultural preferences and other geographical diversity. So we took into account, we follow the similar pattern of guideline as we followed by this neuropathic pain special interest group. And based on that, we publish our guideline considering all these important factors. So as I already told you that on the basis of these great recommendations, pregabalin, gabapentin, all these drugs, they have a strong recommendation, and they are being recommended at first line therapy in the management of neuropathic pain. they have a good number of trials with high quality evidence, high level of evidence is there, and they found that there's a drug response radiate with these drugs, except in patients with HIV-related polyneuropathy, where there were a very high placebo responses, but there are few trials which are negative also. And once they come out with good level of evidence with pregabalin, they said that the number needed to treat, that is 1 in 8 patient has a good response, more than 50% pain relief with these drugs. So, they have a good level of evidence. The quality of evidence is strong. Number needed to harm is 1 out of 14 patients will probably leave the trial and will not have an adequate response, or because of certain side effects, he is not comfortable with the drug. He could stop the drug and switch over to some other drug. But overall, it's a high level of evidence with pregabalin. With gabapentin also, there are a good number of positive trials are there, and the level of evidence is again strong. It's the level 1 evidence. They found that it's the number needed of treat is almost similar, that 1 in 7 patients, 1 or 6 patients have an adequate response to drug therapy. But the important thing here to mention is the number needed to harm. That here the safety profile of gabapentin, they found it's better than pregabalin. And they said that here it's 1 out of 26 patients. If you see it here, 1 out of 25 patients or 26 patients will leave the drug because of certain side effects. So the safety profile they found of gabapentin is relatively better as compared to pregabalin, although both the drugs have a good level of evidence. Now, the combination of these drugs with other drugs may be used in patients who are responsive to monotherapy, but once you achieve a moderate dose of drug with a moderate dose of a particular drug, that's with monotherapy, to reach to a moderate dose of therapy, and in spite of that, if you do not found that there is an adequate response, yes, then you can switch over to a combination therapy. The last, but now this is our Indian consensus guideline. And here also we have first line with a strong level of recommendations for both pregabalin and gabapentin. The only thing here is the difference in the doses of the drug, especially the initiation doses of the drug, that we keep it here, considering our Asian population with low BMI, and there are certain other factors, they are more sensitive. So we have, especially in elderly patients, we have advised to start with a relatively low doses like pregabalin with 50 milligram at bedtime, and then you can gradually keep on titrating the doses. And the maximum dose is as similar to the doses that is being recommended by the international guidelines. Similarly with gabapentin, patients who are very sensitive, elderly patients, start with a lower dose of drug and then gradually titrate up according to the response and the side effects. So the Indian guidelines, they are very much based on these international guidelines, and we also consider all those factors which are being considered by those international guidelines, in addition to the factors which are important for our Indian population. So I think
right. Thank you, Dr. Hamada. You very rightly said that these, when they actually framed the NUPSAGE guideline, they had almost 25 randomized controlled trials by that time. Of course, majority of them were on post-herpetic neuralgia and diabetic peripheral neuropathy, and they had good number of trials for gabapentin also that time, 14 RCTs, and out of them they had almost 6 RCTs on gabapentin extended release tablet. That's why they have the NNP for that also. So they have a good number of RCTs. I'm sure after 2015, these guidelines are again due for revision, maybe 2020. How much work has been done, they will incorporate that particular one. So we now move on to our next panelist, Dr. Subrata Goswami. Dr. Subrata Goswami, please, could you please enlighten, of course, I can shift on to again to my slides and okay. Okay, right. All right, it is. Anyway, my next question to Dr. Subrata Goswami is that could you please enlighten about the, based on these NUPSAGE guidelines and of course your Indian guidelines which we have framed, could you elaborate on the role of amitriptyline, these tricyclic antidepressants, amitriptyline, nortriptyline, and duloxetine, in the management of neuropathic pain? Dr. Goswami, please.
Yes.
Right.
Can I see?
Yeah, please. Your slides are visible. Thank you.
Basically, amitriptyline is a tricyclic antidepressant and is similar to this serotonin and norepinephrine reuptake inhibitors, it acts. We know we have the descending inhibitory pathway, the first order neurons. From the first order neurons in the descending analgesic pathway, 5-hydroxytryptamine as well as norepinephrine is liberated as neurotransmitters,
right?
and which goes to the respective receptors. And in the receptors, then for the further action. And this serotonin and norepinephrine both are taken up by the reuptake transporter. This TCA, amitriptyline, blocks that, reduce that. So more this norepinephrine and serotonin will be available for the descending analgesia system. This norepinephrine reuptake inhibition, it enhances this analgesic receptor. Also, this amitriptyline helps in opening the potassium channels. So in the postsynaptic membrane also, there is further hyperpolarization. So the excitability is further decreased. So, and increasing this noradrenaline, which actually is prepared in the locus coeruleus, in the near the our midbrain. There, these noradrenalines, they are brought down in the descending noradrenaline pathway till that substantia gelatinosa, where this norepinephrine and these serotonins, they activate the neurons, interneurons. These interneurons in turn release the endogenous opioids like enkephalines.
Sorry for the interruption, Dr. Goswami. Can you move your slides? Next slide, please.
Yes.
People are asking for slides.
No, can you see the slide? No.
Only first slide. Only first slide I can see.
No, I am moving. But can you not? I am moving.
Everyone is saying slides not visible.
No, slides not visible. Only first slide is visible.
Okay, I'm sorry. I found that. I do not know how to do that.
I think yes. Now
Yes.
Now it's okay.
Yes. Yeah. Please go ahead. Yeah.
So now we can see.
Yes.
Okay.
Yes.
Yes. Okay.
This is what I was telling, that this norepinephrine, it reuptake inhibition, it will enhance the analgesic effect, mainly through the alpha-2 adrenergic receptor. Also, the potassium channels, these are open in the postsynaptic membrane, so further hyperpolarization and the excitability is decreased. So it acts in other way also, and also in the locus coeruleus, which is at the midbrain, that prepares the noradrenaline. So this locus coeruleus will send this noradrenaline through the descending pathway, and where it will now release, it will stimulate the inhibitory substance pathway, interneurons, so that the endogenous opioids like enkephalines or dynorphins are liberated along with the GABA. So it acts in these. So nortriptyline actually helps in all those steps. Also, it has been also found that it has got some local anesthetic effect. It blocks some voltage gated sodium channels, and also by some additional mechanism of activating the immune system. So it is also helpful for neuropathic pain. And we have seen this, that NNT to TCA to inhibit peripheral neuropathies is very good. It is 2 to 3 as per this publication. TCA can directly interfere with NMDA receptor. It can block also. It can numb the NMDA receptor. So it has multiple actions, and it is also that's why it is helpful by so many of the neuropathic, as already told by my previous speakers. And the last, this reference is we are taking mostly for the IJP and everywhere, and it is a very Lancet publication. It says that. So this is all about how amitriptyline helps.
And I also talked about the duloxetine, the SNRIs,
Yes.
SNRIs, duloxetine.
Yes, so duloxetine also, it is also an SNRI. So it has shown efficacy in painful diabetic neuropathy and low back pain also. And these SNRIs, they have been proven to be effective in several neuropathic conditions. So that according to these studies also, and it has been explained previously. So SNRIs and these TCAs are similar, but TCAs have some additional mechanism of action in different areas also.
Right. So,
and recently in 2020 only, and 2009 only, 19. So there was a publication in the animal experiment, and they have found that the it activates the translocation of the NF kappa beta transcription. That's why the nerve growth factor
Dr. Subrata,
is
Dr. Subrata, your slide's still not changing. It is just
can you change your slide?
TCA. It is on TCA only.
You have more slides?
No,
Yeah, it is there. Duloxetine is there. It is showing duloxetine. Yeah.
I do not know why it is happening.
Okay.
So this last slide shows in recent publication that duloxetine also inhibits nerve growth factor generation. So it also helps in the central nervous system apart from its serotonin and norepinephrine reuptake functions, inhibition functions. So this is also helpful.
Right. Right. Thank you, Dr. Uswami. You very rightly said, and that is why you find for amitriptyline, I think the NNT is somewhere around 3.6 as published by NUPSIS guidelines, and it is around 6.4 for duloxetine, again by NUPSIS guidelines. And that time in 2015, when they analyzed all these data on amitriptyline, they had, around 18 randomized controlled trials on amitriptyline and on SNRIs, which included, of course, 9 on duloxetine, 9 randomized controlled trials, and of course, 4 randomized controlled trials on venlafaxine. All right. So this is how. Now the next question for you, Dr. Goswami, is that the NUPSIS guidelines. Could you please enlighten us? And elaborate on the point that what do they comment on the role of these transdermal patches, the topical application, the topical creams, and how do we, our Indian guidelines, how do we compare it with that, please?
So can you see this?
Yeah, can you show the slide? You have?
Yes, yes. So can you see?
No, we can't.
Share the slide. Share the screen.
Share screen. Yes. Now
Yeah.
So topical agent, there are many drugs which are used as a topical agent, but mostly successful is lidocaine and capsaicin. And according to this new PSIG group and also the EFNS, according to this neuropathic pain special interest group, they are telling that this is second line for the peripheral neuropathic pain. And when the first line or the oral medications are having with some difficulty this safety. Okay, am I audible?
Yeah, audible. Yes.
Yeah. So particularly in the frail and the elderly patients, then this can be used definitely. In the EFNS, they have told that it is the first line in post-herpetic neuralgia when there is concern about the CNS side effects. And capsaicin is a second line for the peripheral neuropathy, and by the new PSIG, and by the EFNS, it is second line for the neuropathies. Now, according to that great recommendation, which has already been told by my previous speaker, so I'm not explaining that more. The quality of evidence for the capsaicin is high, where the lidocaine is low, and the effect size is a statistical analysis, tolerability, it is moderate to high. And so finally, this capsaicin, actually it acts, and there are other drugs too. They have tried with amitriptyline, ketamine, and the phenytoin also, but it is not that good. So how this
Right.
capsaicin acts? This capsaicin actually acts on the TRPV1 receptor. When it acts on TRPV1 receptor, so TRPV1 is stimulated by temperature more than 45 degrees, the acids, and also some endogenous agonists, and by capsaicin also. So capsaicin, what it does, it lots of calcium will enter into the cell. And when the lots of calciums are entered, this calcium overload will cause actually mitochondrial dysfunction. It also blocks the sodium channels. And this calcium, when it is more plenty in the postsynaptic membrane, it not only makes the mitochondria dysfunctioning, but also it stimulates the enzymes like the protease, activates, which then breaks the cytoskeleton. So the propagation of the action potential by the microtubules is hampered. And as a result, finally what happens, the nerves which are taking the information from the epidermis, the nerves retract. And this, so secondly, so if the nerves are stimulated further, it will not react. This is how capsaicin works. And this,
Right.
yes.
Right. Right. Thank you, Dr. Goswami. You very rightly said that the biggest one is 8% capsaicin. Obviously, we know it's not available in India, but and the problem is, that there has been a lot of talk of publication bias. Let me tell you, if you really read those NUPSIS guidelines, you will see that 8% capsaicin patch, this particular one, though there are 7-8 randomized control trials till 2015 and many more after that, there have been publication bias. So that's a big problem with 8% capsaicin patch. And the other one is actually no one knows on the long-term use and the long-term consequences of 8% capsaicin patch as regards to the degeneration of the epidermal nerve fibers. That's a big problem. How far you are able to degenerate those epidermal nerve fibers, that's a big problem. So it has a publication bias, there is no doubt, because many times things are commercially driven. You're right. About lidocaine patch, yes, you very rightly said they have almost 4 or 5 randomized control trials. So far so good. Because we have to leave time at the end for the questions. A lot of questions coming over there, and of course someone talking about ketamine cream and the control drug. Obviously their things are not available in India as such. But yes, now we move on further to leave space for the questions as such over here. Thank you so much, Dr. Goswami. Now my next question, of course, here is we're coming back to Dr. Hamad. That what exactly is, could you elaborate on the role of your Botox, the one which you talked about, and Botox as far as the NUPSIS guidelines are concerned and the Indian guidelines? And you very rightly said that Botox is one entity which is, no doubt it is expensive, but in certain cases of intractable neuropathic pain, it does play an important role if you are not exceeding that particular dose limit of 200 or 300 units. Dr. Hamad, please.
Okay, sir. Thank you. Sir, is my screen visible now?
Yeah, you have a slide, so you can project the slide if you have.
I'm showing it. I'm not sure it is coming or not here.
No problem. No problem. Even you can discuss otherwise also. No problem.
It is not coming
No
on the
problem.
screen.
No problem.
Because
Please.
I just want to show some important thing here.
Yeah.
Just a minute, sir. I'm not able to understand. How should I show my slide here?
Are you sharing your screen?
Yeah. I'm showing it here, but it's not coming.
Share your screen.
Just a minute. It's not coming. I don't know. Share screen. Yes, it's there.
Okay, if he's up, I'll go make.
It's not coming again. Just a minute.
It's 11 hours.
It's coming on my screen, but I'm not able to project it here on the.
So we have actually moved on to third line of drugs. That's what Dr. Hamad is going to talk about, Botox. And then we'll move on to strong opioids and the weak opioid. Dr. Ahmed, yeah,
Is it coming now?
no,
No,
not
it's
now.
not coming.
It's not coming. So,
So till he figures it out, can we move to next topic?
Please.
okay, all right, okay. We move on to Dr. Devinder now. Now, Dr. Devinder is there. I can't
Yeah,
see him.
he's there in the name of iPad.
Okay,
He's-
Dr.
Yeah, Hamad, we can see Hamad's screen.
Oh yes, now we can see. Yeah, that's right. Dr. Hamad, please. Dr. Hamad, please.
I just no, okay, fine. So
Right.
this is what I just want to emphasize here, that Botox is being recommended as a third line of agent because we have very few trials on Botox till this time, and we have a one positive trial, which is a small trial, but we have a large number of trials which are still being unpublished. It shows a negative response. So generally, if you safety profile is good, but the recommendation is weak because of a lack of large number of trials. There are very few trials conducted on this. But as I emphasized in the beginning, that this particular agent has a particular important role to play in one particular condition. This is my next slide. I just want to move to the next slide. That this is one particular condition which is important to show is a patient with peripheral sensitization. And in patients of peripheral sensitization, as I said, the patients who have a painful peripheral neuropathic conditions, in that case, Botox has a good role to play, and it was found that I just want to share it here, that topical agents in this particular sensitive phenotypes of thermal hyperalgesia, or you can say of patients with painful neuropathic conditions, peripheral neuropathic conditions, patients which have a neuropathy because of the peripheral nerve injury, basically. Here, if the topical agents have important role to play, especially patients who have a sort of thermal hyperalgesia. And in those cases, all topical agents, they have found an important response, they show an important response here. And similarly, the Botox has important role to play in patients who are having peripheral sensitizations. In other conditions of neuropathic pain condition, in the other etiologies, probably the role of Botox is not so important here. I just want to highlight one more point here. You can see it here, that the sodium channel blockers, like the drug which has come up nowadays, like oxcarbazepine, which is a more safer drug than carbamazepine, and it's being used in peripheral neuropathic pain. And recently, there are a good number of trials which is being conducted in 2019 and 20, which showed that this drug also is helpful in patients with painful peripheral neuropathic conditions, as like your
Right.
topical agents. So this is an important thing I just
Okay.
want to highlight.
Thank you, Dr. Hamad. You are absolutely correct. There have been good number of almost 6, 7, 8 randomized RCTs with Botox, and the most wonderful part you see actually is really hard to believe the NNT is lowest out of all the drugs. The NNT is lowest for Botox, whereas it was 7.7 for pregabalin. It is 1.9 only for Botox. It is 1.9 only for Botox. So that's something which is hard to believe, but the figures are like that. And this is where, again, you know, that you find that, yes, in selective cases, you can use it. Good. So we now move on to another set of drugs. We will come back on the combination of drugs, and we are moving on to, you know, the opioids. Dr. Devinder is there. Please, Dr. Devinder, Dr. Devinder, because I just want, anyway, if he is not there, anyway, we'll discuss about it. You know, the role of opioids, and what do these guidelines talk about? You know, the strong opioid and the weak opioids. If Dr. Devinder is not there, can I?
I can hear you, sir. I can hear you.
Okay. Oh, Dr. Devinder is there. Great.
Yes, sir.
Great. Welcome, Dr. Devinder. So, could you
Thank
please elaborate on the on the latest guidelines? That means we are talking of the NUPSAGE as well as the Indian guidelines and the role of strong opioids, right? Once upon a time, you know, these oxycodone and morphine were so popular. And so what about the strong opioid, and what about the weak opioid like tramadol and tapentadol? Could you please enlighten us?
Sir, my slides are not prepared because I was not aware
problem.
about
You can talk about
I can
it.
tell. See, the strong opioids, what we have evolved nowadays, there are some partial agonist, antagonist, and the other are strong opioids. Among the partial agonist, antagonist are the tramadol and tapentadol, which have been used, and they are probably partially responsive to the weak to moderate neuropathic pain. But once the pain becomes very severe, I hope, because this the guidelines are such that in the severe pain, only the partial effect is on the pain, not the full effect, because we cannot control severe neuropathic pain with only opioids, whether it may be a partial agonist antagonist or a pure agonist. They can only be used as an adjuvant. But we have to rely on the first line, second line, and third line drugs. That is the alpha 2 delta agonists like gabapentin and sodium channel blockers like oxcarbazepine, as Dr. Ahmad said. And the third line we can add are the opioids, which act as a adjuvant drugs along with the other first line and the second line drugs to control the pain. Because single drug, whatever strength you use, whether it is a morphine or codeine or hydromorphone or anything, they cannot attain the full recovery. And also I would like to say that whenever there is a problem where after using 2 or 3 lines of drug along with the opioids, the pain is not well controlled, there is a role of steroids also. The short tapering doses of steroid of 1 to 2 weeks, it again helps to recover the threshold of other drugs also. After the use of 1 week to 2 weeks of steroid, the drugs which were not responding, they again become responsive. So that is how the guidelines show, and we are managing the patients.
Right, wonderful. Dr. Devinder, you very rightly said, in fact, when they were framing these NUPSIS guidelines, that time they had, a sum up of almost 13 randomized controlled trials on strong opioids, right? And they were mainly on oxycodone and morphine. In those trials, they had used maximum 180 milligram per day of morphine in those particular trials, right? And they concluded that, yes, it has to be in the third line of drugs, no doubt. The NNT which they calculated was coming somewhere around 4.3 for strong opioids, right? So you very rightly talked about the strong opioid. About the weak opioid also, you said tramadol, tapentadol, no doubt about it. In tramadol, of course, definitely, they have put it in the second line of drugs. All of us know it very well. And the reason being, so it comes in the category of weak recommendation, but it is in the second line of drug. And they say that, yes, they could locate almost by that time 7 RCTs on tramadol and almost 1 positive and 1 negative RCT on tapentadol. That was their figure that particular time till 2015. Of course, it included one of our study also, which got published in 2013, Pain Practice. And they said that, yes, even Indian guidelines, when we have taken up the measure here, that, yes, you have to titrate it gradually to a maximum of around 100 milligram TDS or QID, which is again quite a high figure, according to the tolerability profile of the patient. We all know that, yes, the nausea, vomiting, constipation, and dizziness produced by tramadol. So all those things have to be kept in mind. You very rightly said. And tapentadol, if you actually see tapentadol, we have another category. We talked about strong recommendation. We talked about weak recommendation in the NUPSIS guidelines. There is one which is inconclusive. Inconclusive recommendation, that particular category includes almost 7-8 drugs, which includes tapentadol. They have located tapentadol in the inconclusive because you really can't conclude whether it is favorable or we are against that. And this also in the inconclusive one, they also have some of the other drugs which are, some of the, very surprisingly, they till that time they had an NMDA antagonist. Right, so that means till that time the ketamine was there in the inconclusive one, but I'm sure after that a good number of studies have come, so it is going to change. And then some of the other like topiramate, which is used for prophylaxis of migraine. Topiramate also was inconclusive. The other drug which is zonisamide, right, from snails, found in the ocean and all that, and the natural synthetic as well as even topical clonidine was inconclusive. Carbamazine till that time was inconclusive. Of course, they were not talking about trigeminal neuralgia, but the general statement. And the 0.075% capsaicin cream was also inconclusive. So the list actually included not many of them. It is just that it's my duty to sum up that. Now we move on to another category of drugs where in the NUPSIS guidelines you will find cannabinoids. Now, cannabinoids, again, Dr. Devinder, can you please enlighten us on cannabinoids? What are the recommendations for cannabinoid, cannabis sativa? Dr. Devinder, please.
Cannabinoids, they have the similar type of role as a partial agonist antagonist because they are also absolutely not very effective on the chronic neuropathic pain, especially the severe type of pain. But still the guidelines are such that it also acts as an adjuvant. And I would say there is no very much promising role of cannabinoids in the strong neuropathic pain. And it is almost a similar way as we go on with the opioids. There is no significant difference in the guidelines for the opioids or the cannabinoids in terms of neuropathic pain.
That's right. And you're absolutely correct. You know, till 2015, they had 9 randomized controlled trials, out of which 2 were positive RCTs on cannabinoids, but their role is doubtful, definitely. So that's why you can't come in and comment on that. It will remain inconclusive for us, no doubt about it. Now, moving on to, certain other drugs, which we have, yes, you talked about steroids. Very rightly,
Steroids are
very rightly, Dr. Devinder, you talked about. In fact,
especially in
what I would say is
CRPS.
that you wanted to say something? Yeah,
Yeah,
right,
especially in CRPS. In CRPS, what the guidelines are there whenever we diagnose a patient of CRPS and we do a bone scanning, and
right,
and in bone scanning, when there is an active uptake in the affected part, then there are the early role of steroids and the drugs like and a strong anti-inflammatory like indomethacin. They
yeah,
have a good role in the early CRPS when you detect a strong uptake in the your bone scans. So
right,
steroids are useful not in all type of neuropathies, but still especially the CRPS and the compression neuropathies,
right,
peripheral neuropathies, they are
right.
responsive, but only
So,
the tapering doses of steroid, not on a very long therapy basis.
right. Thank you. So when we move on to NUPSIS guidelines again and the Indian guidelines, let me tell you the conclusion drawn by the experts in this particular guidelines were that the current evidence is not very convincing. So you can't say that, it's not convincing to the extent to accept or to refute the role of corticosteroid. These were the conclusions drawn by the experts, and there is definitely a need to generate further evidence to support the utility of corticosteroid in the management of neuropathic pain. You need many more trials to come up. But yes, steroids have been found useful, as you said, in some of those cancer-induced neuropathic pain, sometimes even persistent post-surgical pain. And again, in post-herpetic neuralgia, you find that steroids have been found ineffective. Majority of the trials found them ineffective in preventing neuralgia. Right, so that's one thing which you very rightly brought about the role of corticosteroids. One thing more which I wanted to touch upon and which we left in between was the combination therapies. Now, the combination therapy, everyone, we very frequently we have been using combination of gabapentin plus norepinephrine. Now, what do these guidelines actually say? You can refer to the Cochrane database 2012 and many other references in the 2012 Cochrane database, and the one after that, the Shapiro and Gilron, they've done maximum work, and they found that they found 21 RCTs were included in the meta-analysis, and they reported that time, of course, that gabapentin and opioid was superior to gabapentin alone. So let me tell you, this is what they concluded. But later on, with the misuse of opioid and the opioid crisis happening in American continent and European and elsewhere, they had to change. And there was no doubt that better efficacy was there when they were using this combination, but the frequency of adverse effect was quite high. In the Indian scenario, when we frame these guidelines, our experts, in India, you have those FDCs or fixed drug combinations, like the one you have gabapentin with norepinephrine, or you have pregabalin with norepinephrine, which are available in the market. Now, here the superiority and the advantage which you have, whether you talk about 75 milligram pregabalin with 10 mg, this norepinephrine or whatever it is, or gabapentin norepinephrine, you find that there is no doubt they have a better efficacy. It's a synergistic action, and it also improves your treatment adherence, and which in the Indian scenario where compliance to therapy is generally poor. So that is the advantage here, that in the Indian scenario, yes, definitely these FDCs or fixed dose combinations which you have. The only disadvantage is that you don't have that flexibility. If I want to increase my norepinephrine separately from 10 to 12 or 10 to 15, that will not be possible. But then, yes, to a certain extent, they are doing a good job, and I'm sure we'll listen to the participation at the end. So that's one thing which I thought we'll talk about, combination therapies. And the other one which you have is still remaining. I know there were questions on the nutrition and on the, but before that, yes, let me talk about methyl methylcobalamin, because methylcobalamin and this combination with pregabalin, so many preparations available in the market, but the current evidence actually is not convincing to accept or refute the role of methylcobalamin in neuropathic pain. And there is definitely a need to generate further evidence to support the utility of methylcobalamin along with pregabalin, or whichever way you want to say. So that was the conclusion drawn by experts in this particular framing of the guidelines. And in fact, a Cochrane review, which is in 2008 I'm talking about, which concluded that evidence from RCTs is insufficient. And it is insufficient till today. If you really talk about the role of methylcobalamin, along with pregabalin. Systematic reviews, another one which appeared in 2005, only 2 trials were fairly good quality, I accept that. And the last one, the latest one, which you will find, which has been published in the annals of Indian Academy of Neurology, the neurologists are also doing good work. And they found that addition of methylcobalamin, 750 microgram, along with ALA or alpha lipoic acid, 100 milligram to pregabalin, improves the efficacy of pregabalin and improves, they have documented there's an increase in the nerve conduction velocity. So that's another thing, that documentation, that when you're using this combination of methylcobalamin along with alpha lipoic acid in that particular dosage, it results in increase in nerve conduction velocity in diabetic peripheral neuropathy. They did this work in diabetic peripheral neuropathy involving more than 150 patients and involving 3 groups. So this is what I thought I must. Now we come back to again the last one which is there, is that in the NUPSIG guidelines they have certain things which are there as drugs which falling in the category of weak against. I would be requesting Dr. Dipinder. Is she there, Dr. Dipinder? Otherwise, yes, we can just go ahead. The one was weak against, another was strong against. And NUPSIG guidelines mention weak against. They include 2 drugs. Obviously, sodium valproate. Sodium valproate we know has no analgesic action. And even cannabinoids, what Dr. Devinder was talking about. So sodium valproate and cannabinoids, they fall in the category of weak against recommendation. Initially, we were talking of weak for recommendation. This is weak against recommendation. Then another one is strong against recommendation, where we find, almost 20 years back, we were actually taught, in the sense that in the sense by books and whatever books, literature we're seeing, maxilitine had an important role in neuropathic pain and all that. Now it is all absurd. The role of maxilitine as such is absolutely nil, and rather they say strongly against the use of maxilitine, and even your commonly used drug levetiracetam. The neurologists use the commonest anti-epileptic nowadays is levetiracetam. So both these drugs, levetiracetam and maxilitine, fall in the category of strongly against, no need of using them. So these are the things which I thought will sum up all our findings and the recommendations and the guidelines. And is there anything else which you would like to narrate, any one of you? Because then we take up the questions accordingly. Am I right?
Proceed for questions.
Can I, yeah, that's right. Is it okay? I can just share the screen and then we'll go on to the screen. Yes, that's right. We'll go on to the questions after that. We'll go on to this one. And this is where I see, okay, I'll just move on and I'm finishing. Then I'll take up the questions from the audience. Right. Now, we have a few things which are coming up. Of course, we have covered up all that. And I was talking about combination therapy and 7 RCTs, 2 RCTs, they were, of course, 2 RCTs in those 7 RCTs in the combination therapy, they found that gabapentin, when combined to morphine or to nortriptyline, was superior to monotherapy, even at reduced dosages with no more side effect happening over there. So this is one thing which I thought in the combination therapy, the take-home message must appear over there. And the other one, of course, I think I've talked about the combination of, duloxetine also, definitely, that showed but there have been one study, the largest study, that showed no difference in the efficacy of side effect when pregabalin combined to duloxetine, that means 300 milligram combined with 60 milligram of duloxetine, and another one at high dosages of 600 milligram pregabalin and 120 milligram duloxetine. That normally we tend to use 20 milligram BID and all that, sometimes 30 milligram BID, but this 120 milligram duloxetine daily is a very high dose, especially for Indian patients, and even 600 milligram pregabalin is quite high. All right. So we have talked about that. Lidocaine patch, yes, we did talk about it. Strong opioid we have covered up. And then we talked about strongly against, and Botox has been covered up. And I think we go on to a corticosteroid, we have covered up. Inconclusive, we have covered up. Methylcobalamin, we have covered up. This was the maintained study that I was talking about in diabetic peripheral neuropathy. Methylcobalamin and alpha lipoic acid combined for 12 weeks therapy showed improvement, in sleep, pain, as well as increase in nerve conduction velocity. That was from the annals of the, done by neurologists, of course. And then finally, when I sum up with this new guidelines for future trials, they have also recommended you conduct, more studies in the pediatric population. So far, we have all talked about adults and adults. Let me tell you, the evidence was all from adult studies. And we must use ISSP diagnostic criteria, we always use, and validated screening tools, no doubt about it. And classification should be based on sensory phenotype, which Dr. Hamad was talking about, the sensory profile and the sensory phenotype. And longer follow-up is definitely needed, something like usually 6 months or beyond that is considered as a long follow-up in any study. Sometimes it may be difficult, but you should exclude patients with low intensity pain and high variability of pain at baseline. So that's another thing. So this is when you are conducting these studies, so one has to keep all these things in mind. So to conclude, I would like to emphasize here again, before we take up those questions, that yes, we have done a sum up of right from the time, where we started with the definition and the underlying causes, and then we moved on to assessment. But yes, I agree, in the assessment part, we could not cover up that, but here we can, everyone knows that you have been assessing neuropathic pain on the basis of those tools, and the famous one she talked about, DN4, or in French we call it as Dahlia Neuropathic 4. That's the one by Boschera. And another one which was devised by Boschera was on the NPQ, not the NPQ, but the NPSI, or Neuropathic Pain Symptom Inventory. That's another one. These are two. The third one which has been is ID Pain by Portenoy. And then the fourth one, which is LANSS, Lens Pain Scale, or what is commonly known as Leeds Assessment of Neuropathic Pain Symptoms and Signs. Right? And then the next one in the series is Pain Detect Questionnaire. All of you know, that's by Fryan et al. The Pain Detect Questionnaire is so famous. And they also have another one which is known as NPQ, or Neuropathic Pain Questionnaire. In the Indian guideline, the experts actually said that they are more in favor of DN4 and NPQ. That's Neuropathic Pain Questionnaire, right? They're least time consuming. And with DN4, rather, when Dr. Dipender was talking about, it has a good predictive value of almost to the extent of 86%, the sensitivity being around 82%, and the specificity being around 89%. Another one brought out by Germans is the German Research Network, right, on neuropathic pain testing, but it involves QST, and that's mainly for research, right? So that's the German pain research network. And of course, Magel Pain Questionnaire you can always use. So these are the one which the commonly used neuropathic pain assessment tools. So when I was concluding, yes, there is immense need to generate, more epidemiological data from the Indian continent, and of course from the Asian continent also, and in different neuropathic pain conditions that we have in India. And as Dr. Hamad and others had rightly pointed out, that yes, both genomics and sensory profiling, they show some promises in predicting the treatment efficacy. They show some promises in the latest research. But then, when we talk about large-scale genomics, I won't be talking because I have good number of contribution in the genomics, but the most important thing in the large-scale genomics is data security and data storage and data integration. These three things are very important when you're talking of large-scale genomics. That means data security, data storage, and data integration. So, they have some promise to offer, and these promises are there in predicting the treatment efficacy, both the sensory profiles, sensory phenotypes, and the genomics, no doubt. So using the simple algorithm based on sensory profiling or sensory phenotype, and you can see that it could lead us to more in the direction of stratified treatment approaches and more personalized therapy in future. So maybe in the next 5 or 10 years, you will find that, and it shall go a long way in reducing the therapeutic failures, which you have in neuropathic pain, and in reducing the substantial burden on the community as a whole. So which is our prime aim, that yes, we want to alleviate the pain and suffering of the mankind. So now we have rest of the time for question answer, please. And this is where I'll require the help of Dr. Pankaj, of all our panelists, as well as Dr. Kailash Kothari, please.
Hello, sir. There's one question. What is the role of magnesium? Role of magnesium? Any role of magnesium? Any evidence on that?
Right. Okay. Dr. Kailash, can we start with the beginning? I have noted down certain questions.
Sure. You can go ahead. Yeah.
Am I right?
Sure.
Because that person must get preference. I think I can answer this.
We have around 15 to 20 minutes, so you
right.
can cover as many as possible.
Absolutely.
Yeah.
Thank you so much. And Dr. Kailash, you must be seeing that we have not at all touched upon the interventions in neuropathic pain and all those kind of interventions, because it's not the forum for that. We can have another one. And in fact, whenever these guidelines have been framed, they have never brought out the interventional pain management in those guidelines.
Right.
So we are sticking on to, rather you can say, pharmacotherapy. All right. So the first question was on the anxiety, or the anxiety produced by neuropathic pain. Well, you can see here, I don't know who did ask about this question, but it's a very good question. It's a very good question. Chronic pain as such is again a cause for a lot of distress, lot of panic, and lot of anxiety, no doubt about it, And on top of that, if you have a neuropathic pain, just imagine, the patient has been having those, those lancinating pain sensation, the burning sensation, and that pressure like and the squeezing sensation which are there, and that makes his life so uncomfortable. So obviously they are going onto that particular stage of high degree of anxiety. And not only that, this particular event indirectly producing anxiety, but you also have an imbalancing between the excitatory and inhibitory neurotransmitters. As Dr. Hamad and Dr. Goswami were talking about, that you have excessive release of excitatory neurotransmitters. So obviously when there is a balance going more in the release of excitatory neurotransmitters, and any of the condition, post-herpetic neuralgia, diabetic neuropathy, or any one of those, then you obviously find that yes, the inhibitory neurotransmitters, they get suppressed. So this imbalance also naturally leads on to high degree of anxiety. And the moment you are going to activate your descending inhibitory pain pathway, that means indirectly you are putting brakes onto the incoming noxious painful stimuli, and by increasing the level of serotonin in the central nervous system by any of those drugs which we talked about, then you find yes, definitely the anxiety level will go down. So this high degree of anxiety definitely is an essential and integral part of neuropathic pain. I hope I have been able to explain that how exactly you are going to have, especially in the light of the peripheral sensitization. You can't touch any part of your body to a particular hitting element, and you have the central sensitization, and you also have wind up phenomena happening over there. So that's the thing which is actually creating problem. Now before I'm sure this explains the element on anxiety, and before I hand it to the panelists to actually enlighten us more on different aspects, someone actually raised the question of the thermal one also. I think Dr. Rekha or someone raised the question on thermal one. Yeah, that's right. Now the thermal, the thing is what they have seen, they have been using mainly in neuropathic pain, the skin biopsies for research. They have been using, this, what we talked about, the role of QST, what we talked about microneurography. Now the element on a thermal one is very insignificant one, but yes, it is very much there. And they are, corroborating it mainly with the indirect effect on the sympathetic nervous system. Usually when you have the thermogram and thermogram showing something to highlighting, you can have two types of thermogram, one happening in the peripheries, in the upper limb, lower limb, and the other one happening right in the central nervous system. What you indirectly notice and elaborate with the help of functional MRI, those firing points which are seen in functional MRI. So the role, actually the sensitivity and specificity of those thermograms in neuropathic pain, purely neuropathic pain, is not very clear, but more evidence is required, more studies are needed. But yes, indirectly, definitely, as you are talking about the disturbance and the decrease in the intraepidermal nerve fibers, and you're finding the abnormal firing pattern happening with the help of the microneurography, you find that yes, it may have an important role to play maybe in near future. So that's something, that's all I can talk about. Now the other one question was on the role of DRG in central sensitization. Well, that's very important, and I did talk about DRG in central sensitization. Let me come back again to that. It's something like that there is, these afferent pain signals are actually moving in the direction, and when they are moving the direction from peripheral nociceptors onto the spinal neurons, right? They activate the low threshold mechanoreceptors, which are located at the level of the dorsal horn. Am I right? They activate those low threshold mechanoreceptors. So what is the consequence is that there is amplification of the central neural response to the noxious stimulus which is coming. This is known as central sensitization, right? I hope I have been able to explain. Now, in the whole cycle, then what happens is that touch, which may acquire the ability to produce pain, right? That results in secondary hyperalgesia and allodynia appearing over there. This is all part of the central sensitization phenomena happening over there. In the same time, a lot of neurotransmitters are being released, which are involved in the modulation of pain perception. They are actually modulating the pain perception, right? So this again results in a complex interplay of events, and which actually underlie the pathology of this, and it is a kind of an unending loop. If you have seen a loop and it is unending, so that cycle continues till you actually intervene and use your pharmacotherapy. The last part over there in the central sensitization is the neuroplasticity and wind-up phenomena. Now, let us see it this way, that wind-up phenomena is the central and the temporal summation of all the excitatory impulses which are happening. This is following the repeated firing happening in the dorsal horn neurons as a result of C fiber discharge. Now, here I'm talking of the firing of the dorsal horn neurons as a result of or due to C fiber discharges which are happening constantly. So that is a wind-up phenomena where there is a temporal summation of all the excitatory impulses. Now, how it begins? It begins with glutamate. Glutamate tends to bind with NMDA receptors, right? And also AMPA receptors. So glutamate binds with NMDA receptors, AMPA receptors, together with the release of various neurotransmitters, including substance P, right? This substance P is released from the C fiber. So again, this is what is happening, okay? And this rapid sensitization of NMDA receptors ultimately and further contributes to what is known as hyperexcitability of the membrane. So you see, your whole membrane is getting hyperexcited, right? And that hyperexcitation of the membrane results in what I was calling as an unending loop. All right. So this wind-up phenomena, neuroplasticity, central sensitization, they're all part, in addition to what I talked about in the beginning, peripheral sensitization phenomena. All right. So now we take up, and I'll take the help of the panelists, certain other questions which are there. Yes, Dr. Kailash, you were talking about the role of magnesium. One of the questions was there, the role of magnesium, right? So can I request Dr. Hamad to talk about the role of magnesium, in this particular phenomena, the neuropathic pain management, right?
Actually, see, if you see the randomized control trials which conducted on magnesium, we still have, as you said, very inconclusive evidence. We do not have a very clear-cut evidence regarding the role of magnesium sulfate in patients of neuropathic pain. There are very few trials which are being conducted, but the evidence is not very strong and it's inconclusive. That's what I would say. Nothing more.
Okay.
If you want to highlight somewhere else.
Okay, thank you. There was one more. Thank you, Dr. Hamad. There was one more question. I would request Dr. Goswami to please, help this fellow. This is on the role of vitamin E. The role of vitamin E in the management of neuropathic pain. Dr. Goswami, please.
Still now the saying I should reply that there is no good evidence on vitamin E on neuropathic pain, and probably the magnesium issue came with as we know that NMDA is plugged with magnesium so that it will not allow to enter calcium in the postsynaptic membrane. So some studies were done, but as Dr. Osmani rightly told that there are only 2 studies and which did not show any good result.
Right. The one more question which I noted down, of course, let me cover up that one, is actually on the role of methylcobalamin. There was question in neuropathic pain, and I think I did answer, but I can repeat also.
You did cover it, sir.
Right. I think the current evidence is not convincing
I
accept or
suggest
refute.
that somebody was asking, and it's a very common question for people who are starting their pain practice, that how you start your treatment for neuropathic pain, how long you should try for first line of treatment, if it is not working, how to shift on second line, or how long you can give first line of treatment.
Wonderful,
like pregabalin. So these
Yeah.
are the common questions.
Yeah, that's right. Very good question. So I would be requesting Dr. Hamad. He talked about the starting, how to initiate pregabalin, gabapentin, and then go on. Dr. Hamad, please. Dr. Hamad, please.
Yeah. Thank you, sir. Again, I just want to say that we start with the first line of drug. We have, we have 5 drugs here: pregabalin, gabapentin, duloxetine, amitriptyline. And these are the 4 common drugs which are recommended as first line of drugs. Now you have to start with the lowest possible dose, like especially in patients who are highly sensitive, elderly population. But you start with both monotherapy. Only one particular drug will start in the beginning. You choose any one of them according to the affordability and according to the advantage, disadvantages, and then you have to increase the doses, titrate the doses, and you have to reach to a certain level, and that is what recommended in the textbooks, moderate doses. So in Indian population, if you see, I said the 600 milligram. If you are starting 100 milligram of gabapentin, then switch over to 300, then 600 milligram is the moderate dose of gabapentin. So if you're not getting response at that particular time, only then you have to add another drug.
So how long you have to wait till you change the dosage to from low to high? 3 days, 7 days?
Yes,
How
sir.
much you wait?
Yeah, it's written at least for 2 weeks, minimum 2 weeks. 2 to
Okay.
4 weeks is being recommended here. So you should wait at least for 2 weeks, minimum 2 weeks, and then you can add another drug from level 1, from the level 1 evidence group itself, or you can use a level 2 evidence group in which we have other drugs like tramadol, and there are other drugs like topical agents are there, and oxcarbazepine is there now in level 2 group also. So you can add on the drug from the level 1 itself, use a combination of drug from the level 1, or you can add on the level 2 drug. But now here again, I just want to emphasize here again that it's important here. Now this time, when you see your patient after this discussion, you always have a look on the sensory phenotype also. If you find that, especially what I said amongst the 3, that patients have which type of phenotype is predominant in that patient. Is it the peripheral sensitization, lot sort of peripheral sensitization, or is like a central sensitization, which is predominating here, or some more of a sensory loss and the patient is showing depressive symptoms. So accordingly, you can choose your therapy wisely. Now, on the basis of sensory phenotypes, and then you can add on the second drug from the level 1 evidence group, and then you can add a drug if you still required from the level 2 evidence group, and that's how we can move on with the combination of drugs.
So for any dose, whatever dosage you have you have started, you have to at least wait for 10 days to 14 days for effect to come, and then change the dosage.
That's
Yeah,
right. That's right.
that's yeah.
Okay. So
There
about
was, yeah,
yes,
yeah,
sir.
yeah,
Yes.
please.
Now there was a question about Botox. Okay,
Right, right.
how to decide about site of any experience in whether in Botox injection, where to inject, how much you inject, what are
That's
the
right.
recommendation about the dosage and all.
So
Well,
here
this is where, okay. I'll just add 2 lines and then Dr. Hamad.
Sure,
We have used Botox mainly in post-herpetic neuralgia, right? Some of those intractable, and I'll tell you, my series is on supraorbital post-herpetic neuralgia. The supraorbital one many times is not responding, and despite all the blocks which you have given, and even you have used your neurolytic agent at the supraorbital groove, and you've used almost 4 to 6 or 8 weeks of therapy with pregabalin. You see, the point here is they have seen, and what we actually do, we have used around 75 to 100 units of pregabalin. I'm so sorry, Botox we have been using. And this is where we choose multiple points, and we are simply going intradermal, or not even subcutaneous, but deeper than that. And intradermal points, we have done the pain mapping, and having defined the pain mapping, then you are using these points almost maybe to the extent of 5, 6, or 7 in the ipsilateral side. Mostly it's ipsilateral side which is actually there. So the point here is that it may or may not work. Yes, definitely. But we have seen that in these kind of refractory, I should say, refractory or intractable neuropathic pain, especially my experiences in post-herpetic neuralgia, where I've used, I found good results. At least initially when we were getting only 30 or 35 or 40% relief, here we have been getting, continuing pregabalin. I will not say that we stop pregabalin. So you can say an integrated approach along with pregabalin and Botox, and the dosage was around 75 to 100 units, being very careful that yes, you are not close to the eyelid, because many times the pain is there, and then you can always produce ptosis if you are close to that point, and just intradermal, and asking the patient to wait for at least 48 to 72 hours for the effect to come up. It's like that. And you can, obviously you'll have to repeat. You may have
So
to repeat
what are the good cases where you can use Botox? Because in neuropathy, sometimes it is a very large area, sometimes it is very localized. So what is your recommendation where you should use it?
Dr. Hamad wanted to talk about. Yeah.
I just want to add one more indication here. Botox initially come for, management of spasticity. So I found it useful in patients of, central post-stroke pain, like patients having spasticity with pain. So I've used in a few conditions, patients coming with, spasticity of the shoulder girdle, I've seen with pain, lot of pain, and patient with, hemiparesis on one side, spasticity on one side, and is complaining of pain and spasticity both together. So in those cases, I found it useful to manage injection Botox. So that's another indication which I particularly found it useful to use Botox for the management of pain and spasticity.
Okay.
There is a question on Botox in intercostal nerve distribution by Dr. Nankar. There's a question coming up. Well, I can say here that if you have a patient of intercostal neuralgia, I don't think, that if I push in my drug, but, it's the last resort. We should not use it as a first line or second line. And I would rather say that pertaining to this particular question on the intercostal one, I would say that having failed with all your pregabalin therapy and all your intercostal, maybe you have done intercostal blocks, steroid, or even pulse radio frequency, whatever you have used. If you are failing, then I think one can try. But one can try, and obviously it will remain as subcutaneous or intradermal. Yeah.
Any use of baclofen in combination therapy? Can it increase the responsiveness? Any recommendation on that?
At least in the guidelines, as far as the baclofen is concerned, it finds no place in the guidelines, no doubt. But
Okay.
it's a very good suggestion, definitely, Dr. Kailash. I think one should keep it in mind. Why not? Because many times you are using your baclofen, 10 mg, 25 mg, BID or whatever it is, and people are getting relief with that, no doubt. Even if it is minimal, but yeah, absolutely.
In patients of pain with spasticity, pain with spasticity, again the Botox, baclofen has a role to play.
Right. There was one question which came up, if I am correct, was on CBT, on the role of
Yes, I
cognitive
was just
behavioral
coming to
therapy
that. Yeah.
in neuropathic
Psychological
pain.
interventions.
That's right. That's right. Well, it's a very good question. When we talk of cognitive therapy or when we talk of relaxation exercises and all that, I think in CBT, our prime objective is to identify and changing the overtly negative thoughts which are coming in the brain. So, which actually might be contributing to the problematic finding indirectly. Obviously, it's mind-body interaction all the time, or you can say mind-body-soul, whatever you may say. So that might be contributing to the problematic finding here. So the point is, as you talked about in the beginning of one of the delegate or even Dr. Kailash, the high degree of anxiety, and then accordingly you have the consequence in the sense there are behavioral problems happening. Avoidance is one of the example of behavioral this thing. So the first step is to learning to actually recognize, as I said, those overtly negative thoughts which are actually coming in the mind. So it's same as, you're eliminating or, those negative thoughts first and trying to reassure yourself, whichever way, trying to reassure yourself, whether by shutting the room and concentrating on the root of your nose, whichever way, again, it comes to those different kind of meditation technique. But meditation is entirely different from what you actually talk about cognitive behavioral thought. So the first step is to be able to learn those overtly negative thoughts. And after that, they have actually a 3-column technique, 3-column, 2-column, whichever way you can say. And accordingly, then bringing and incorporating positive thoughts and reassuring yourself. So it's something like, that it takes time. It takes time means in the sense that CBT sittings are required, which may take around 20 to 30 minutes on a daily basis. You can do 5 days in a week. And CBT as such, but not solely CBT, as an adjunct, always we say, as an adjunct when you're finding inadequate response to the therapy. So CBT as an adjunct, and especially when you see that the person is not willing to have any more injections, they refuse, I don't want to have any more intervention or this thing. So it is something like controlling and gripping your emotional and those kind of behavioral consequences of your negative thoughts. So it is something like that. That's what we say CBT. Now it has an important role to play. There is, I will not say substantial body of evidence, but there is some evidence that yes, it has an important role to play, both in they have seen in post-herpetic neuralgia, there are reports, as well as in some of those conditions which are not purely neuropathic, like if we say a chronic low back pain, which is not purely many times low back pain, but it has an important role to play. So I say that yes.
In general, chronic pain, even neuropathic pain is chronic pain. So it has some psychological component. So
Right.
it is
Absolutely.
going to develop over time. And if you
Absolutely.
have facility
Absolutely.
for a psychologist in your pain department,
That's
you
right.
should always take help of them. So
Yeah.
it will definitely help.
Professor Saxena,
Yeah.
may, I-
Yeah.
may,
Yeah.
I-
Oh, sorry.
may I add something?
Yeah. Please, sir. Please, Dr. Pankaj. Sure.
So another very important practical issue is that whenever we are diagnosing a patient with a neuropathic pain and we are starting with the medication, we had to explain to the patient very thoroughly that what we are treating and why we are starting these medications.
Absolutely. Absolutely.
Because this is going to be long-term treatment, and we have to explain them that we are starting with a low dosage just to see also to see the side effect profile of your body
Right.
when you're starting with these doses.
Right.
So we have to explain them that we have to increase your doses. We might have to change the medications. We might have to add some medications, because if we don't explain all these things before we start the medications, the compliance becomes very poor. And another important thing is that
Very important. Yes.
we must explain them why we are starting these medication, because most of the time what happens then when the patient goes to the pharmacist to buy these medications, he'll ask what medicine is this. They'll say, oh, this is for the seizure. Are you suffering from some seizures? So they'll say,
Exactly.
oh, it's
Exactly.
anticonvulsant. Oh, are you suffering from depression? This is how the pharmacist will
Exactly.
say. So
Very
they,
important.
why doctor is giving me antidepressants? Why is giving me seizure medications? So we need to explain them very thoroughly that why we are starting these medications. And the most important thing is we have to explain them that we'll have to frequently change your medications. That is, I think, the most practical point we
Very
must.
important.
Perfect. So Dr.
Very
Pankaj, we are
important.
running short of
Wonderful.
time.
These
So
are
we can,
tips.
if
Yeah.
some more questions are there, we can cover. Dr. Saxena.
Yeah. Yeah. I think I saw something coming as a paste coming up over there for neuropathic pain, if I'm
Any
correct.
special neuropathic paste available?
Page.
Yeah. That's,
Page and all this.
yeah. Well, to the best of my knowledge, of course, Dr. Goswami can always enlighten us. Yes, initially, that was 2-3 years back. They came with the purpose of, sir, can you do a trial on this? And it was actually an amitriptyline cream which they had devised. Now, you see, those kind of things you may find in the market, but if you really look at the evidence, it's very difficult. Even with capsaicin 0.075%, capsaicin cream, which is usually available, it is very difficult to say that, yes, solely the paste will do magic in neuropathic pain. It has to be a multimodal integrated approach. And so I won't say that, yes, you start with the paste, whatever. If I say capsaicin cream, I won't say that you start with the capsaicin cream, but definitely if it is a milder category and you find that it is just the beginning and you're finding only few peripheral nociceptors have actually been activated, it's very fresh, but then okay. But then if it is an established case of neuropathic pain, you really have to have, the first line drugs first, and then maybe over a period of time, gradually you can add those creams which are there. But if I really say those amitriptyline paste or clonidine paste, there are transdermal clonidine patches available abroad, but not here. So, and those clonidine patches which have been used abroad are transdermal, are mainly have been used for CRPS and those kind of patients. So, very difficult for me to say that, yes, they have an important role to play, but as an adjunct, yes, capsaicin cream along with the first line of drug. That's for sure. Dr. Pankaj, if you want to say something.
Whatever this cream or paste and these things or Botox and everything are for some local problem. So if there is a generalized problem, generalized neuropathic pain and a wider area, then these are not useful. So that should be kept in the mind.
Absolutely, yeah.
So there is one question regarding the serotonin syndrome with the combination medications. So do you have any experience of? Have you ever
Dr. Hamad wanted to say something. Dr. Hamad.
Thank you. That this is a common phenomenon that we see. The combination of serotonin, norepinephrine reuptake inhibitors with tramadol. That is what is mentioned in the literature. Although I've not seen any such evidence. Could be initially patient may be complained of mild tremors, autonomic, hyperactivity is there, excessive sweating, tremors, confusion, excessive salivation. And then finally, the patient, if you do not manage in time, could lead to seizures and other serious side effects. But it's mentioned in the textbooks that the combination of tramadol with serotonin non-reuptake could precipitate the serotonergic syndromes. But practically, we have not yet seen any such patient. And I think Saxena sir has told that there is certain genotypes, particular specific patient population who are more prone to such side effects. If you could highlight it further.
Yeah, they have functional gain of SCN9A, that particular genome, where they find that yes, it may happen. But again, things are not very clear about it, and I don't think I have no personal experience with this particular one. Definitely.
Okay.
Yeah.
But I do prefer not to give tramadol and duloxetine simultaneously.
Yeah, that's right. That's
exactly.
Right.
That's
Yeah.
right.
Better
That's
to
right.
avoid.
Yeah.
Any other question we have, sir? I think we have covered most.
I think we have covered up, unless until
anything in pregnant patient. It's important part. Dr. Pratibha Mache, she want to ask about
that's right.
neuropathic medication in pregnant patient.
Dr. Goswami, can you? Dr. Pratibha. Dr. Goswami, please.
So for the pregnancy, I don't think these medicines act centrally, and so local medications are more useful. I think the which are absorbed systematically, these medications to be avoided as far as possible. But in the early pregnancy, there is no side effect about the, particularly in the mid trimester. In the first trimester to be avoided, but in the mid trimester, we can use all the medication, so we do not discontinue that. And
yes,
in the
right.
So that is to be explained to the
patient. Any word on? I think we have to cut short the things.
Right.
Any role of EMG, NCV?
Yeah, that's right, Dr. Kailash. In fact, there is hardly any role of EMG, if I can say. NCV still, they have the typical role they have explained for microneurography, QST, or the skin biopsies and those kind of things. EMG, they say when things like associated pain along with some kind of hemiparesis or paraparesis, then yes, you can do that. But NCV, or nerve conduction velocity, has an important role to play. But that's again mainly for research. When you're seeing the role, as I said, methylcobalamin and alpha lipoic acid, and you find after substantial period, say 4 to 6 weeks, you find increase in nerve conduction velocity. Okay, from the baseline, I can say yes, there is an improvement, along with improved pain relief and improved sleep. So NCV can play an important role in diabetic peripheral neuropathy, especially those things. But about EMG, very limited role.
Okay, sir. We need to close here. Fantastic discussion.
Continue.
Thank you so much.
Continue for some more time. 5 minutes. We are uploading that video.
Okay.
Continue for. You can take some more questions.
And in meanwhile, people has to take part in survey. Just reminder, as many people as possible.
Yeah, we have sent us a link also here also, and also uploaded on the website ISSP ISSP.
You can cover one important topic is neuropathic pain in children.
Oh yes, that's right.
So you can have few words on that.
Yeah, we were trying to cover up that also. It was not possible. But then yes, there is not much data which is available on the work which has been done on the role of all these pharmacotherapeutic approaches. Yes, definitely the pediatric population also you can't ignore. Many of them would be suffering from that. They do have an evidence, and in fact the NUPSIG guidelines, in fact, in the finally they say that yes, lot of work and lot of evidence needs to be generated, especially for the pediatric population. That's for sure.
What are the recommendation for common patients, like patients having chronic renal disease or hepatic diseases?
Oh yes, that's a very good question. For chronic kidney disease, chronic liver failure, or mild or moderate or severe liver dysfunction, severe renal dysfunction, I think the most important thing, or if I can ask Dr. Hamad, because you need to titrate your dosages again, very important. And you can, based on your creatinine clearance rate, CCR. Dr. Hamad, would you like to enlighten on that aspect?
Yeah, as such, these drugs, they do not have any organ toxicity, but you have to reduce the doses of the drugs. Once you give to these patients, like you start with the lowest possible dose, as I said, and titrated up And then accordingly, here, instead of going to a very high dose, you can use a combination of drugs, or you can use a moderate dose of a drug. But as such, these drugs do not cause any organ toxicity. They do not damage liver or kidney, but yes, you have to reduce the doses in such patients.
I can add one thing, 1 minute.
Yeah, please, Dr. Goswami.
For the neuropathic pain, mostly a very important thing is the patient's education. The patient should be educated about the problem. Then only lots of stress and this deleting the stressful memories.
Very important.
That is very important. Many times they have seen that the MRI, lots of big discs. So if we can explain that if in spite of this disc, you don't have any problem, you don't have any sensory deficit, don't have any motor weakness. So this is not causing the problem. Everyone of us, many people are having this. Then immediately we find that the patients are happy and the lots of stresses are deleted. So that's also a form of this cognitive
absolutely.
behavior for the day one.
Yeah, absolutely. And what Dr. Hamad was talking about, I would just like to add one sentence that even with amitriptyline, when they have used more than 100 milligram per day, there have been reports of sudden cardiac death. So we got to be very careful with the dosages, within limits you are working, you're using 25 or 50 mg of amitriptyline, and 75, is a very rare entity and those kind of things. So and what Dr. Goswami talked about is also wonderful. We need to be.
And
definitely.
Better to be avoided
Dr. Kailash.
In the elder patients, better to be avoided amitriptyline. So
I think one more important thing is patient with congestive cardiac failure or this thing. So pregabalin can cause cardiac this thing.
Absolutely. That's important point. Yeah, definitely.
In peripheral vascular disease, the leg edema. That is also important with pregabalin and gabapentin.
There's a question on peripheral vascular disease here in the management of pain in peripheral vascular disease. Here, I just want to highlight in here that you can use a neuropathic drugs. In addition, you can use a sympathetic blocks. We are not going to detail into that, but yes, we do use in our practice stellate ganglion block for upper limb and lumbar sympathetic blocks for lower limb. So you can combine these block interventions with these drug therapy to get the optimum response in patients with patients with neuropathic pain with peripheral vascular disease.
Right.
We have Dr. Pravesh Kanthed. He want to just put some his thoughts.
Pravesh,
Pravesh, you can talk.
Yeah. Good morning, everyone.
Good morning.
Just a clinical question I wanted to ask. Suppose if we have a patient with, say, neuropathic pain over the distribution of face, and we are in doubt that it is a trigeminal neuralgia or a neuropathy. So how do we clinically proceed such a case? If we have a patient, say, who is having burning and pricking sensation in around the cheekbone and the mandible, how do we clinically approach this patient?
Dr. Goswami, can you?
So if the problem is that there are two types, one is neuralgic, another is neuropathic. Neuralgic, that is short lasting, and that is maybe after stimulation of the A beta fibers, and so that is short lasting. And then there is cross connection in the inside the base of the brain. So the A beta fiber stimulations they are also perceived with the A delta, and this is the reason. But the neuropathic pain, that means the pain is continuous. So there is no intermittent. In neuralgia, there is intermittent pain, and then these sodium channel blockers are more helpful. In neuropathy, when there is burning pain, there is electric current-like pain, or this hyperalgesia, these things denote that there is neuropathic pain. Small fiber neuropathy, C fibers also has been involved. Then you can add this gabapentin or pregabalin or nortriptyline, amitriptyline, etc., duloxetine. So these roles are there. Otherwise, there is no role of adding this gabapentin or pregabalin for blocking the ascending pathway, or no role for amitriptyline or duloxetine. If the pain is intermittent, then only you can add carbamazepine, and also you can add baclofen if necessary. So that is recommended. And
okay, all right. So we are ready with the video now.
Okay, I think we should conclude this session.
Yeah,
it was fantastically.
Thank you so much. Thank you.
Conducted
Thank you,
session
Dr.
with covering
I
almost
must thank all the panelists.
All of
Thank you,
you,
Thank you,
Dr.
sir.
Pankaj.
Thank
all
you.
of you, please stay here, sir. All of you, please stay here.
Please stay
Thank you.
back.
Have
Yeah,
a,
yeah.
have
Stay
a look at
healthy.
this video.
Stay healthy.
So Dr. Hitesh Patel has created something for the lockdown period and involving all the pain physicians, and he has made a beautiful video. So he's just going to share this video to all of you. So over to Hitesh. Hitesh.
Yeah. Before that, we have received many suggestions from members and also from many other people that we should have some webinar on some extracurricular activities apart from academics, like some skill development or personality development, or maybe how to write paper and all. So we are thinking about that. I think we are coming up with some new topics, so it will be interesting lockdown period. So Hitesh, you can proceed now.
Can you see the thumbnail, sir?
Yeah. ये क्या बनाया है हितेश? Just you can tell some background about it, why you thought of making this. आवाज नहीं आ रहा? We are not sound is not there.
हाँ सर वो
ये कौन है?
sir.
Sir, you will not be able to play during call. So you have to either connect on your computer screen and then show it.
Yeah sir वो ट्रांसफर लेकिन अभी तो नहीं होगा. It's very difficult.
Okay, then I think
We'll send you on WhatsApp and Facebook, sir.
Okay, fine.
Yeah.
So I think because of technical issue, because during call you cannot on mobile you cannot show this.
Yes, sir. I don't know. Sorry about it, sir.
So you are ready with it. You can just release it on
Sure.
YouTube or Facebook.
Facebook and WhatsApp.
And also you can send us. So if
Sure.
we all agree, we can put on our website also, because it's by pain physicians.
Yeah, sure, sir.
Congratulations for this. So Pankaj.
For a wonderful discussion. We had a really good interactive discussion. A lot of questions were there and very relevant questions were there. And I hope that everybody enjoyed this panel discussion. And as Dr. Kailash Kothari mentioned, that since the lockdown has been extended, so we'll be coming with a more innovative ideas in the future, next 2 weeks. Let's hope for the best, what we can get out of us. So I thank all of you, all the panelists. Thank you so much for this wonderful session. And with this, we can close the session. And I just request our president to just give his closing remarks.
Yes, and with this very elaborated discussion, I think we end this session, and we hope to see you again in next of the webinar, maybe a little different from what we have right now. And we are also, you can also write to us what exactly you would like to hear from these things, and like any other topic other than academics or something. So we are getting good suggestions. So we'll think about it. Thank you very much, everyone. Have a nice day. Be safe at home. Don't go out.
Thank you, President Saab.
Please
And
participate.
thank you, Secretary and Dr. Saxena, for a wonderful session.
Please participate in the survey. That is very important for us, for the society. Please participate. Yes. It's been uploaded on the website also, on the Facebook page. ISSP Facebook page is there. You can go to the Facebook page. You can see here, Facebook Society. You can click here also, or you can go to the website, or you can go to this link. So you have multiple options available. Okay. So thanks to all of you. Thank you very much.
Thank you.
Thank you, sir.
Okay.
Thank you. Bye-bye.
I'm just exiting now.
Yeah.
Thank you.
Thank you, sir. Thank you.
Thank you.